Well, if anything, the coronavirus pandemic has shown how much a reliable public health benefit plan is needed. It's still not clear, though, how government is planning to fund the national health insurance. Let's discuss this now with Professor Alex van Heerden from the Wits School of Governance. Prof, good afternoon. Welcome to the Midday View on eNCA. I guess the majority view is that the country does need a kind of a national universal insurance of sorts. But the question that comes up now and again is how will this be funded, among many others? I mean, people are saying, where will the money come from? And once it's there, it will make the NHI one of the biggest state-funded enterprises. And then governance will become an issue as well.
Yeah, so the first problem with the proposals is that it implies that you're going to create your basic benefit that everybody would access would be provided by a single monopoly provider, a sort of a health ESCOM, if you will. And the problem with that is that many healthcare systems in developing countries on the whole, and many industrialized countries just do not have that model. It's actually not a very efficient model as well. And holds very enormous governance risks. But the proposal that's on the table implies that it would have to raise taxes equivalent to what people are spending in the private sector and more. So the fiscal proposal, the public finance proposal itself, involves an astronomical increase in taxes, which really clearly hasn't been thought through and is very unnecessary in order to achieve a universal coverage strategy. You don't require it. It's not an essential requirement in order to create a very good system that covers everybody.
And the tax base currently is too strained anyway, and unemployment has gone up, and many businesses have been folding as well. And besides other wastage that we hear about and report about, it's going to really be difficult to see where this money is going to come from.
Even before COVID, it wasn't feasible, and it's not feasible within sort of 15 to 20 years as a strategy. So even if you adopted an incremental approach, it's not going to work.
How do you then create, affordable access to health care, to good health care that the people need and constitutionally in this country is a right?
So you have to have a tax-based, a well-functioning tax-funded system. You also want to enable a framework that allows people who are earning adequate incomes to co-contribute to their own care. And you can subsidize them to a minimum degree because in order to achieve the universal aspect, but you do not need to provide their care. So this is typically the model you'll find around the world, is that basically you have this complementary regime to your tax-funded and provided regime. But you definitely have to look at mixed models of funding and provision. You do not put all your eggs in one basket. And the systems tend to be highly decentralized in terms of how they function and how the specific organization of healthcare occurs. That's not the model that's proposed. So the model that's proposed essentially says it will outlaw all other forms of financing healthcare, pretty much the way ESCOM outlawed anybody else from providing and distributing electricity. And the results will pretty much be the same. You will end up with a highly inefficient, very centralized system, quite aside from the patronage risks that come from creating a very concentrating power in the hands of the executive of government, who in the proposals have immense power over the procurement process.
Yeah, and like ESCOM, finally, as we heard yesterday, the President, now companies, private entities are going to be allowed to produce and supply and sell back to ESCOM 100 megawatts. So you might find yourself in future having to review if you don't start it properly. But I see that it's moving on. From the reports I've seen earlier that phase 3 is coming and there might be some mandatory prepayments of sorts of the new scheme and the contracting of accredited private hospital and specialists. So it looks like the government is moving with the NHI. Are there lessons currently with the pandemic, besides the points you've made, that they should take into account? Because, I mean, you look around, it's pretty much a dismal kind of performance.
It's been an appalling performance under COVID, particularly where you centralize key decision-making. So what you end up with, pretty much as with ESCOM and we've seen with the vaccine strategy, is that if government basically sits on their hands, everybody else has to sit there and watch, and nobody else can take any kind of action. So government is actually a critical player in being able to ensure equitable access, but it doesn't have to be the provider, but it can certainly create the framework in which you have equitable access. But what it's trying to do is to do everything. And the problem there is it actually just doesn't have the capability to do that. And so consequently, it just fails. And in Eskom, you're seeing that where finally you just have to give in and realize that your central planning processes, which are supposed to be so efficient, have resulted in incredible cost increases in electricity provision, massive downtimes, undersupply, massive corruption. All of that is what would face us when we actually try to introduce something that we don't have, which is a health Eskom. We do have to decentralize it. We need a different kind of system. And certainly we'd be in a different position today if we were running the vaccine strategy differently.
Yeah, so I guess what you are saying is, yes, we need to create the right environment, the right frameworks to afford people access to affordable healthcare, good quality healthcare. But the model as it sits today, and knowing the history of the country and looking at where we are currently, might not deliver the results that are desired.
That's correct. I mean, the assumption is that we want to build some sort of system that looks like the National Health Service in the United Kingdom. The problem with that approach is that you cannot cut and paste a health system from one country to the other. And the NHS spent years trying to decentralize the over-centralized model, and it is a very, very difficult and unwieldy system as it operates. And there are many alternative regimes that provide very high-quality universal health coverage that don't involve that degree of centralization. The more decentralized they are, provided you've got effective resource allocation to ensure equitable access. In other words, you pool sufficiently to make sure that you're not leaving anybody behind in terms of coverage. But you do not have to produce everything. And the moment you introduce that kind of regime, we end up having to sit and watch people bungle provision. And it's not just South Africa. It's pretty much every environment where you try to do it, because it's just a bad institutional model. It's not how you run a good health system.